Our third speaker for this morning is one of our colleagues here from the University of Rochester. Solomon Abiola is a research associate with Dr. Ray Dorsey here at the University of Rochester, where he works on mHealth strategies for chronic conditions such as Parkinson's disease and infectious diseases such as Ebola. Mr. Abiola received a BSc in Mechanical and Aerospace Engineering from Princeton University and an MS in Biomedical Engineering from Carnegie Mellon University. This fall, he will be starting a joint PhD in Translational Biomedical Science and Computer Science at the University of Rochester. As a Nigerian American, Mr. Abiola's global health research has ranged from novel technology to eradicate malaria parasites to applications of telemedicine and mHealth in emerging economies. He seeks to view healthcare in these regions through what he calls a prevention intervention management protocol. Mr. Abiola will today present his talk entitled Combating Ebola and Beyond in Real Time Using Smartphones. Please welcome Mr. Abiola.
Good morning, everyone, and thank you for inviting me here to present on my research. So today I'm going to be presenting on basically combating Ebola and looking at other infectious diseases and health concerns through the aspect of smartphone technologies, or what you know as mobile health. Just to give you a brief outline, I'm going to give you why we're looking at this in the background, and obviously what was the framework that led to me developing this platform, and then going beyond that in what I call the prevention intervention management protocol. So before we start, everybody talks a lot about mobile health and big data when it comes to healthcare, both in the US and internationally. And I like to show this graph simply just to give you guys an overview of where these technologies stand. So right now, a lot of this is hyped up technologies, but they're about 5 to 10 years out in terms of the development track. So that means is that, we're hearing a lot about it in the news, but basically, how can we actually realize these goals? We see mobile health being used for surveying and so forth, but how can we use it for things like diagnostics or detecting if someone has high blood pressure or other conditions? So why do we want to do mobile health in Africa or other developing continents and countries? Primarily because by the year 2017, about 330 million people across the continent will have access to smartphone technologies. So this isn't just about solving today's problems, but really being prepared for a future of infectious diseases. We are winding down with Ebola, but South Korea is now faced with MERS. Where will be the next outbreak? Could we have another SARS outbreak or swine flu outbreak? Just to give a background about my team, I'm working with Henry Kautz over in our Data Institute, and also Professor Dr. Ray Dorsey, who's a neurologist by training, but does a lot of telemedicine work with Parkinson's disease patients. So as my colleague mentioned before me, a key thing that's important here is the socio-economic landscape when it comes to these countries. If you look at this graph here, since the Ebola outbreak, we funded Liberia with about $1.8 billion in funding, but a lot of this did not go to supporting infrastructure. So this went to fighting just the current problems, and a very few amount of this money actually went to supporting their health infrastructure. And as was previously mentioned, when you look at Rwanda in terms of their health landscape, they have done a better job at mixing these two things. But really, how can mobile health help achieve these goals? Since the Ebola crisis unfolded, there was a decline in maternal mortality cases, and people were improving their vaccination programs, especially with our efforts globally to eradicate polio. But since Ebola hit, a lot of organizations are projecting that these values will drastically increase. So how can we as researchers and health policymakers really make an impact on this immediately before we see a massive uptick in these conditions? So my mobile health project basically began when I was an undergrad at Princeton. What we were looking at was tracking the spread of influenza. So here in the US, this is one of our biggest concerns, is preparing for flu seasons and making sure we don't have a massive epidemic on our hands. But this is basically parallel to looking at other infectious diseases like MERS, Ebola, SARS, etc. So we started by doing a study in March of 2013 where we installed this application in about 6 or so students' cell phones. And the neat thing here was to allow this to be installed straight from the internet. So this wasn't we gave people cell phones or anything, they could download this application online. So with this information in the application shown on the left, known as Node, we basically asked them a few survey questions. So things like, what is your major, to determine which parts of the campus they were utilizing, what was their view on vaccines, and so forth. So we asked these questions because as a health policymaker, you might say, well, oh, let's vaccinate everybody in this community. But as was mentioned previously, some cultural practices might prohibit that from being the best solution. And wouldn't it be nice to know this beforehand, before you say we're going to fund you $2 billion to develop this vaccination program? Additionally, it's also useful to know, well, what are people's views on hygiene? So we asked them things like, how long do you spend washing your hands? This is important to look at things like, if the disease was spread through hand washing or some sort of hygiene aspect, who would be at risk for receiving this infection? With this information, we were then able to look at human mobility patterns. So this is made possible by collecting people's location movements throughout the campus, and we were able to create a real-time map, basically showing their mobility on campus. So in this graph here, we've highlighted a few very dense regions on the campus. This is an aerial view of Princeton's campus. Right here is where the student center is, which makes sense that you would expect to have a lot of interaction in that area. So now you as a health policymaker could say, well, this is where I need to deliver my limited, hospital resources. So this is where I need to deliver a few ambulances, rather than saying, well, we need to scour the entire Princeton population and figure out, how is this disease spreading? So since then, a year went by, and I was in Nigeria last year when we had our first patient zero case. This reminded me of basically the work I was doing as my undergraduate thesis, and the NSF posted a call for proposals. And so I was fortunate enough to write and receive a grant successfully from the NSF, which I'm currently leading, which basically seeks to use this application in Nigeria to help establish a preventive view on infectious diseases, and not just a reactionary view that we typically take when it comes to a lot of global health issues. So we set out to improve the application drastically because we're dealing in a more resource-constrained environment. So things like energy are very limited, so therefore the application had to be something that used minimal resources but still gave us similar data to what we were getting in the Princeton study. This map here that you see is just me and my coworker basically moving throughout the Rochester community. So this is downtown Rochester. This is us right here in the Saunders Research Building. And this is where I live, downtown Rochester. This is where he lives. So you can see now, if you were a health policy worker, you might say, well, I want to know where these two individuals are interacting. You don't have to contact them. You can see this is a hotspot area, that here at the Saunders Research Building, this could be a potential node for an infectious disease outbreak. So I'm just going to outline some of these. You don't have to read all the text here, but basically we had 3 aims with our NSF study, which is basically to see how can we improve the responses to mobile health strategies. Is this something that's feasible? Because as was previously mentioned, you have limited networking capabilities. Do people actually want to receive, prompts saying, do you take your malaria vaccinations or other things like that? How are people going to interact with the platform, and how can we change their behaviors around this? So we hypothesized that this would be a very feasible thing to do. One of our main concerns basically is still looking at the networking problems in terms of, where people are going to receive coverage and how much of their data plan is going to be utilized in terms of delivering this data back to us. And then how we're going to be able to analyze this and feed this back into the existing health infrastructures. So our study, which we are aiming to start this month or early next month, basically seeks to enroll about 100 or so Nigerians in Lagos, Nigeria. So this is where they had patient zero come in from Liberia. And we're seeking to look at this community, both installing the application on health workers, because as was previously mentioned, they're the ones who are the highest mortality rate because they're direct contact with patients, also among students and just the general population. And we're seeking to collect this data over a 3-month period and then feed this information back into the Lagos State Ministry of Health. So why are we really interested in this technology? If we look at a lot of our current approaches to infectious diseases, they're very subjective. So we give out surveys, we have to physically go to people's houses and so forth. We can't reach everybody everywhere in the country the way that mobile technology has been able to do in a lot of these developing countries. With this platform, however, our hope is that we will be able to do this and therefore then supplement physical efforts to actually send out, helicopters, ambulances, and so forth in real time to these communities. Currently, this is basically what our platform looks like to a healthcare worker or health policymaker. So this allows us to do 4 things. We can locate individuals who may be at risk. So basically this means that everybody's assigned a unique identifier, which is anonymous to that person. So imagine now you have an Ebola case on your hands. Someone's come in, they said they're sick. Okay, you're doing the proper treatment for them, but the question is, how are you gonna do contact tracing? You have to physically go out to these communities, but with this platform, I can basically show you in real time who they've interacted with, all within 5 minutes. So now you can do everything that would take you maybe days, or if the person comes in their comatose state, or they've died, you can do all this in real time. Additionally, the next level of this is prevention. So by using this mobile health data, how can we say, well, what if this person had Ebola? What if here in the US we don't have Ebola right now, but what if one of us in this room had it? What would happen to the rest of the New York State? How long would it take to infect all of America or the world? And we can do that using geospatial information from this platform, and not just mathematical modeling, which might say, well, we expect within 2 weeks, 200,000 New Yorkers will be infected. Well, where are those New Yorkers? New York is a very big state. We are in remote communities. You have Utica and so forth in all these communities. It's similar to a lot of developing countries in the sense that it takes time to get out to these areas. And all of these areas are New York City, where you have plenty of hospitals that can immediately respond to a health crisis. So currently we are getting our local IRB approval, and we're looking to start collecting our data in a couple of weeks. We've already started to do so with beta testers just to make sure that the infrastructure can support the study that we're about to launch. So now to what I call the Prevention Intervention Management Protocol. So there's 3 components to this protocol, and what we're looking to do is focus first on prevention. So this is obviously, right now, none of us are infected, we're all healthy individuals, but what would happen if someone had an infection? How can we immediately react to that and not be reactive? Intervention is looking at some of us might be at risk for high blood pressure, or somebody in West Africa, is hypertensive. What intervention strategies can we use this platform to immediately enact change? And lastly, management. So there, obviously we're focusing on a lot of infectious and non-communicable diseases, but what about the aging population? As these countries, grow up, they're going to require, issues. They're going to face problems like Parkinson's disease. They're going to face, different mental health issues. How can we support those infrastructures? So I'm going to show you just briefly 2 projects that we're doing here in the U.S. that I think would be applicable and helping to support some of the problems that Ebola has caused. So the first is we are running a telemedicine network here at Rochester with other institutions across the United States. This basically consists of visiting patients via a simple platform similar to Skype. So the analogous example is looking at, well, with Ebola, there's been an increase, obviously, in maternal mortality. What can we do using telemedicine to provide similar care without having to visit those women? Because some of them might feel, well, if I go to the hospital, they're going to say I have Ebola, and then they're going to keep me and my child there. Or their husband might say, well, don't go to the hospital because I don't want you guys to contract Ebola. That means that woman is going to stay at home now, and she might be at risk for some complication during pregnancy. What can we do in terms of using their cellular device? Say, okay, well, you can have an OBGYN visit you remotely. We can give you some advice to help with your pregnancy, or give you some advice to help with your AIDS medication during an Ebola outbreak. Even here in the US, when we had our Ebola cases, we only had the capacity to handle 9 patients. So imagine if we had 30 Ebola cases. We'd be facing similar crises to some of these African countries as we as a country try to rapidly scale up our ability to fight Ebola. So how can telemedicine basically support these things? Secondly, I mentioned mobile health, and obviously I'm using this platform for infectious disease, but here at Rochester, we've already working with Apple, used a similar aspect of mobile health to support Parkinson's disease patients. This comes down to how do we empower individuals? A lot of our work is seeking to say, okay, we're going to take a top-down approach to say, our Ministry of Health will help people who are sick and so forth, but there are people in these communities who believe that, they can help themselves. There are local resources that might be able to help them with some of their basic medical needs. What can we do to create applications that will allow them to use their local clinics to support some of their health needs and not have a continual reliance on, well, I have to go to the city to get, simple care, when there's actually someone in the village who might have experience, someone who's a health worker can help with that pregnancy. So with that, If there's any questions, please ask them. Thank you.
Hello, I love this idea. I think it's very brilliant. I'm working at I do research here at the National NCBHR, and we have video phones that we use for our research. And I have two questions for you. The first being language barriers. Also, literacy issues can also be a problem. People often will stop going to school because they have to raise a family, and there's literacy issues. So I'm wondering how you'll address those issues. Secondly, if a family has a phone that they share amongst each other, how would you track individual people in those cases?
Okay, so those are two very good questions, and thank you. So the first one is basically looking at the literacy barriers in terms of either the people, people can't understand English, as was mentioned previously, or maybe, they're, using their local language. And so this is one of the concerns that when I was talking to the president of the Nigerian Academy of Sciences, he had with the research, which was looking at, well, what can we do to translate the English platform to other languages? And so this is something that I've been working with students in the Nigerian institutions to help them become more empowered and aware of their own community's health, is to help them translate this program into those languages. So that is one way to look at how we're going to overcome the literacy barrier. But I don't think there's just this project that's going to be able to do that. I think there's also, government and other NGO activities in terms of building up the local education of the population. The second question was basically looking at, well, in some communities, and even here in the US, some of us might not have a smartphone. We have the one person in the family who has a smartphone, the rest of us don't have a phone, or something like that. So this isn't just an end-all solution. This is kind of looking at the future where most people are going to end up having cell phones, on a per-person basis, just because of the rapid growth of the mobile technology across Africa. So it is a problem now, but we don't see it being a problem in the next decade. And so that's really where this project is focusing on. Is let's be ready for the next 10 years, while other people, such as the CDC, World Health Organization, currently focus on a lot of our health problems today.
Good morning. Simple question. So your presentation had to do with smartphones, but at least in my experience, the progression was dumb phone first and then a smartphone. Can you speak to how far dumb phones have penetrated, and if there's a potential to use texting capacity to make steps now while we wait for the rest of the population to be able to get a smartphone?
Yes, so dumb phones, if you want to refer to them as that, there's a lot of them, have penetrated across Africa and just the world. We're probably looking at, let's say 80% penetration, whereas smartphone technology, if you look at Liberia, Sierra Leone, and so forth, we're looking at maybe 20 to 30%, in places like Nigeria and Ghana, 70 to 80%. But, nobody's at 100% threshold in terms of that technology. As I mentioned earlier, we're trying to focus on smartphones to be ready for the future, but obviously a lot of people out here, are doing mobile health with texting initiatives. And so there have been research efforts looking into, let's say I could create a digital call center where you could interact with that and text and say, well, I have a fever of 105 degrees Fahrenheit, ask us some questions and so forth. That could be set up as a texting service. And we can still collect location information from that, because every time you send in a text message, you're sending that to a cell phone tower, which has a physical location and address. So there has been research efforts, I know, done by Carnegie Mellon, Harvard School of Public Health. They looked at this with malaria transmission in Kenya. And they were basically finding out that in those areas, the malaria was coming in from the remote communities, because they had done a lot of work in the cities to try and clean up, the water, do a lot of malaria vaccination programs. It was like, why is there still so much, so many malaria cases? So that was something that they discovered with that. The reason why we're not using that here is because the accuracy of using a cell phone tower can be 1 to 5 kilometers. So now you're talking about, okay, well, 50,000 people are at risk for Ebola, and it's still, you're back to square one, where it's like, well, we might as well have just gone out there and visited every village. Whereas with this technology, we've been able to reduce that down to something like 20 to 100 meters. So now maybe you have in your window 200 individuals, but that's a lot more manageable in terms of a caseload than 50,000 people.
This is really fantastic work, thank you. To what extent do you think that concerns about the local government and the U.S. government tracking people's movements will be a barrier to participation in this kind of work?
Great question, thanks for the comment. So basically concerns around privacy. And here in the U.S. and globally, after the whole NSA whistleblowing incident and everything, we're all concerned about our privacy. But for those of you who have an Android phone, Google's tracking your current location right now. And a lot of you have consented to this. You're enjoying the fruits of that, Gmail, Google Search, all the technology they're providing you. Facebook is tracking your location. Businesses, as a part of their policy, are tracking your location. Governments are tracking for bioterrorism or whatever purpose is, whether we accept that or not, they want to use it for. But health is lagging. It's not using this for something that actually would be beneficial to you. And so that's one of the technologies that we're trying to, educate people around, is that this tracking is happening. Why wouldn't it be nice if it actually benefits you for once? And one of the things we are also looking into is we do anonymize our user IDs. And despite the fact that on this display, because it's for research, we show you, basically where everyone is. As you can see on our main platform, this only shows you where an actual incident has occurred. So this is it's only showing you where an interaction has occurred and not where someone's previous activities have occurred. So your system will say, okay, these 5 towns have had, interactions with this person you said has Ebola. That's where you need to, go looking. Versus saying, okay, well, I pulled up your entire location history for the last 3 weeks, and you decided to do something, malevolent with it or something like that. So that's sort of the way that we're addressing some of the privacy concerns. At the same time, what we are trying to do is that because a lot of these countries don't have things like HIPAA and so forth, one of the things I'm trying to do with this research is abide by similar internet, U.S. and EU standards. Because if someone is to build upon this research, or a product comes out of it, we have to make sure that it still is respecting people's privacy. The work that was done out in Kenya, it was amazing, but like you mentioned, they just downloaded the cell phone data straight from the tower. Imagine if that happened in the U.S. Imagine them saying, well, we were able to track SARS, but we downloaded everybody's data from Verizon. None of you would be happy about that. There would be multiple lawsuits, people would be leaving Verizon and so forth. But we're not allowed to do that here in the U.S., but we can do it overseas and makes great research, but is that really a practical solution? And so that's why I developed this as an application to say, you're consenting to be part of this. In exchange for that, I'm giving you information if you've been in an Ebola environment. Where's the nearest clinic to receive your AIDS medication? You can use this as a platform to add other things. Look at counterfeit drugs, use it as a telemedicine platform, etc.
Just have a question about user acceptance of this, a little bit beyond the fact of privacy, but in terms of application-wise, if you don't use the app, it's no good. So how do you get people to actually use the application and engage in it, sort of in the pull method?
So the question is asked basically about user engagement, or sort of similar to how we have drug adherence. How do we keep people using the platform continuously? One of the things I've been trying to do is basically provide feedback and minimal interaction with the user. So it's not supposed to be like daily reminder, did you do this or something? But we ask them a basic survey that asks things like quality of life. And this happens bi-weekly. We're also trying to find ways to provide information that they're going to be seeking. So if they are looking for, let's say, a clinic, that's something that, here in the US, we just go to Google and look for it. But in a lot of these countries, there isn't just some, yellow book that has all this information in it. So we're trying to put that on the application to say, okay, you're looking for this, here's where to get this resource, or this has been verified by the government, and things like that, that people actually matter to them in day-to-day life because of the whole counterfeit and various other issues along those lines.
Okay, thank you very much. I'd like to